We're really excited to have you all. We're really excited to hear from Dr. Azza Ahmed. She studied and obtained her doctorate degree in nursing in Cairo, Egypt. She's a certified pediatric nurse practitioner and board certified lactation consultant, a fellow to the International Lactation Consultant Association, and fellow for the Academy of Nursing. Her research program is focused on breastfeeding promotion, education, and support. She's developed and tested interventions to support and improve breastfeeding outcomes to vulnerable populations, including preterm infants and low-income families. She's developed comprehensive telelactation systems and integrated video conferencing and test edit effects in improving breastfeeding outcomes and maternal health. And her research and services have been recognized both nationally and internationally through the Sigma Theta Tau International Honor Society of Nursing's Audrey Hepburn Award for contribution to health and welfare of children, Excellence in Nursing Research Award from the Delta Omicron chapter, the Tony and Mary Holman Health Achievement Award in the field of health sciences research, and the Indiana Public Health Association. We are so excited to have her here to talk to us all, and I am going to just pass the mic over to her. If you do have questions, feel free to put them in the chat, and we'll probably save them for the end, and I will help facilitate that. But again, thank you all for coming. We're really excited to have you.
Thank you, Kelly. So I'm going to share my screen. Is this clear? Okay. So I'm going to start to talk about, I like to start first, usually reminder with why breastfeeding and what are the benefits of breastfeeding, the recommendations from professional organizations, and how can we evaluate our breastfeeding indicators, racial disparities in breastfeeding, and the multi-level causes of disparities, and then how we address disparities. And I will give like a one study sample of my studies. So when we talk about benefit from breastfeeding, for infant, mother's own milk or human milk reduce the risk for respiratory tract infections, otitis media, gastroenteritis, the late onset sepsis in preterm infant, and necrotizing enterocolitis, which is very common in preterm infants. So the stem cells in breast milk actually make a layer to protect the colon in preterm infant and decrease the enterocolitis. And also type 2 diabetes, the sudden unexpected infant death syndrome. Also some protection against lymphoma, leukemia, and Hodgkin disease, and also the obesity and improved cognitive development. So for mothers, we actually have decreased postpartum bleeding due to the effect of the oxytocin, and also that energy or the fat that accumulated during pregnancy is used in breastfeeding and producing milk, and the mothers are usually get earlier back to normal weight earlier compared to formula feeding mothers. Decrease the risk of ovarian and breast cancer. Cancers also protection against cardiovascular and metabolic diseases. And with the lactational amenorrhea, we also decrease the blood loss and also increasing the spacing between the children or the child spacing. And we all know the psychological effect and the bonding between the mother and the baby. And also in terms of mood, our like mental health, successful breastfeeding with all the support from the lactation providers and the family, it really improves the mental health and decrease anxiety, depression, and also stress. But at the same time, you can find conflicting literature about increasing breastfeeding, increase the depression or anxiety, but this is in case of breastfeeding difficulties that is not managed really in a successful way. Also decrease the neuroendocrine response to stressors and the neurodevelopmental outcome, which is a cognitive development. For economic benefits, we all know that there is a lot of money we spend in treating the infections, especially you can see like breastfeeding infants, they have a very, very low incidence of otitis media. So that's decreased the cost of the clinic visits, prescription, and all these costs. And there was a study that by Bartek. She actually calculated the cost, and she and her colleagues reported that if 90% of US mothers would comply with the recommendation of exclusive breastfeeding for 6 months, and we will explain more what's about exclusive breastfeeding, that will actually save around like 13 billion per year. So what are the recommendations from the professional organizations? The American Academy of Pediatrics recommend breastfeeding exclusively, which means without any supplementation, without any water, without any other liquid. So just the mother's milk, human milk for the first 6 months, and then continuing breastfeeding beside the complementary food till 1 year. And the World Health Organization actually recommended exclusive for 6 months, and then with a complementary feeding or like regular diet for 2 years. So how can we actually evaluate or assess breastfeeding? This is a report from the CDC. The CDC actually released a report biannually about the situation. And those are the criteria that they use to evaluate the situation or the current situation. This is the report from 2020, the last report, and breastfeeding or ever breastfed, which is the breastfeeding initiation. Initiation immediately after giving birth, the mother, the baby is put to the breast and starting breastfeeding. And we, according to the recommendation, within the first hour, if actually the situation allowed, without any complications. So, and then breastfeeding, which is like breastfeeding in general, not just exclusive. Could be partial breastfeeding, could be exclusive, around at 6 months, and then 1 year, and then exclusive breastfeeding 3 months and 6 months. And then this is also the report of the employer. So it is by law now that all employers, they have to have a place for the breastfeeding mom or a lactation place to pump or breastfeed, pumping mainly her milk. And also the supplementation with formula within the first 2 days. And you can see the rates. This is the most recent one, as I mentioned. This is the national actually rate, 84% for initiation. We see high initiation and then started to decrease after after going home, or so the continuation rate really we need to work on the continuation rate. 58% at 6 months and 35% at 12 months, with 46% or 47% around exclusive on 3 months and 25 6 months. And when we look at this rate, this is the national rate in the United States. When we compare it to other like developed countries, this is very low. So like, for example, Sweden is 98%, like Australia, 92% initiation, which is this start breastfeeding in the hospital. Canada is 89%. So this is also a very recent report from the CDC about the racial disparities in breastfeeding initiation. And this is, as I mentioned, this is initiation. And you can see the highest is the Asians, based on the race and ethnicity. Asians, 90%, followed by Hispanics, and you can see the lowest is Black, 73%. And as I mentioned, this is the national, and when you look at the report, also provide the states, each state by state rate, and you can see the differences in different in states, like states with high actually percentage of minorities, they have a very low actually space. And it's not just the race, it is also social determinants. It depends on the income, like the higher income, it means higher breastfeeding rate. Depend also on the education, higher educational level for parent or mothers, usually with high rate of breastfeeding, and also the geographical location, like urban or rural areas. In rural areas, breastfeeding rate is also low. So this is the breastfeeding rate at 6 months. And you can see also Asian still high, and also the lowest are Black American mothers. And this is, you can see like 75 for like Asians, and less than 50% for African American or Black American. This is at 12 months, and also you can see the difference in, and also the American Indians, they also have a very low rate. So this is the exclusive breastfeeding rate at 3 months. You can see like white American and Asian still high, but Asians, they have a very high rate of actually supplementation. They have a high rate of supplementation, which like Hispanics and Asians, they also have, like Hispanics, they don't believe that breast milk is enough, so they have a very high rate of formula supplementation. And Asians, they have also supplementation with herbs and teas and all kinds of liquids. So that means also it's not exclusive. And this is exclusive breastfeeding rate at 6 months. And we can see like very actually a low rate of exclusivity. So I'm going to use the social ecological model or framework to try to discuss the reasons for these disparities, and what are like showing the forms of the inequalities in lactation support. So this is one of my colleagues. She did this for African American mothers, and I will discuss like each level separately. So when we talk about individual reasons, so minorities, we all that they have a high rate of complications and morbidities during pregnancy. And especially like African American, they have a very high rate of prematurity compared to other races. Gestational diabetes and obesity, preeclampsia, hypertension, and anxiety and depression, with all this high compared to actually other, like compared to white Americans or other races. So high rate of maternal and infant mortality. All morbidities, all these morbidities could lead to delayed lactation, and or we define it as lactogenesis 2. Delayed lactation is lactogenesis 2 is the milk coming in with difference in dropping down in the hormones and increasing the prolactin hormones. That's actually initiate the milk of the mothers, and we call it milk coming in. And usually it happens within the first 72 hours after giving birth. So lack of knowledge about breastfeeding and what are the benefits, and also what are the risks for what are the risks of not breastfeeding. And I have seen several, I used to volunteer in the WIC office, and I remember I had one mom, and she came to she was actually bottle feeding or formula feeding, and she came to the office and she saw all the benefit of breastfeeding, and she said, wow, I really need to, I want to breastfeed, because she didn't know even the benefit, what are the benefits of breastfeeding. Self-efficacy and self-confidence is a big indicator of for breastfeeding. So low self-confidence and low self-efficacy really affect the breastfeeding duration and also the exclusivity. We see a lot of moms will actually say, I don't have enough milk. So we usually call it perceived insufficient milk. So when we explain, when we actually talk about perceived insufficient milk, when we rule out all the pathological causes, more than 80% is from self-confidence and self-efficacy. And this situation, we talk with the mothers and provide assurance. And if the baby is like growing well, gaining weight on the normal curve, he is doing fine, you have enough milk. So financial strain and including like difficulty meeting the basic needs, and job instability is very, very common among minorities more. And perceived the inconvenience of breastfeeding. Some mothers, they believe that they need to change their lifestyles to be able to actually continue breastfeeding. So when we talk about interpersonal causes, like social support from family members, from friends, from colleagues, from husband, from partners is very, very important. So lack of this support is really, really affect the breastfeeding outcome in terms of initiation, duration, and exclusivity. Lack of the model or role model in their social network, and in some culture, breastfeeding is not the normal actually habit or normal in their culture. And also the belief about big is healthy, and like this is the main cause of supplementation, or providing the formula for to increase the baby's weight. And also another cultural belief is the bottle of cereal, which is like a bottle of cereal will have the baby sleep longer. So when we talk about community factors, in some areas, there is a lot of actually lack of access to lactation support. In desert areas, desert areas defined by the March of Dimes, that this is the areas or counties that they lack like maternity care facilities like hospitals and clinics that provide the maternal prenatal care and maternal care. And lactation also support it's going with this actually desert. So in the areas there is also lack of support from lactation consultants and lack of support of facilities that provide breastfeeding education. Insufficient breastfeeding education from providers like prenatal education. So once the mom gets pregnant, one of the actual education, we need to refer her for prenatal breastfeeding class. And in this situation, there is lack of, of referral and also the education. The work environment, according to the report, only 51% of the employer provide the lactation site or lactation space for the mothers to be able to pump and maintain breast milk, or to maintain their breast milk supplies. The neighborhood is also very important. If it is not really breastfeeding friendly, really affect the mother's ability to continue breastfeeding or to go outside to have with breastfeed the baby, stigmatizing. We have several situations in restaurants with the mothers ashamed about breastfeeding in public. So when we talk about policy and macro systems, the employer also, there is a lot of variations in implementing the maternity leave, the paid maternity leaves, especially in like minorities, mom, they work in really unsupportive work environment. She has to actually quit or affect their breastfeeding ability to go back to work, maybe gradually decrease the breastfeeding or stop breastfeeding to be able to go back to work. Low rate of implementation of evidence-based maternity care practice that is supportive to breastfeeding, and maternity care facilities in the neighborhoods with larger Black and Hispanics, which we call baby-friendly facilities. The baby-friendly initiative started by the WHO in early 90s with implementing at least 10 steps to have the hospital actually support the mothers immediately after giving birth with keeping the baby skin to skin, having the baby with the mother in the room when they started to go to their rooms, which we call it rooming in. Also, they have to have like a breastfeeding policy in the hospital, breastfeeding education to the staff and to the all the staff, all the providers, physicians and nurses, everybody in contact with the mothers. And also no supplementation with formula unless it is medically indicated. So every is biannual. Also this the survey the maternity practices in infant nutrition and care by the CDC that actually assess the situation of the 10 steps. And this is for hospitals that are baby-friendly designated or not. So that's actually the more we want to see how many steps they actually implement in the hospital. A lot of literature also, they indicate that minorities mothers are targeted by formula companies, and formula companies in terms of giving free samples. I don't know how they do that, but once the mother gets pregnant, you can see she receives in the mass in her mail like a packet with the formula or all types of formula. In the past, we used to have, like in the hospital, the mothers go home with the bag with from formula company with free samples, but this is now, it is not allowed in the hospital. So they should actually, it is actually is not allowed in any hospital now, but they sent it to the mother in the mail. So aggressive and unregulated marketing of breast milk substitute result in increase in morbidity and mortality, and a lot of literature supporting that. So for social and the historical context, so we remember the slavery and for African American mothers when they actually forced to breastfeed their slaveholders, the actually slave mothers, breastfeeding for their slave, and they were forced to breastfeed, and that's what actually affected their own child. And in the same time, they were also forced to wean their infant around 6 months to go back to work again. And also Native American mothers with the forced relocation also affected their tradition of breastfeeding, and they changed the habit of natural breastfeeding. So this is one of my colleagues, and she is actually an article for her, Robinson, and she is African American, and she did scoping review about racism, bias, and discrimination. And she was thinking that's a modifiable factor to actually improve breastfeeding among African American mothers. I'm going to provide some highlights from Karen. African American women's experience racism really affected the breastfeeding initiation and duration. And how does that happen? That's the biased assumptions from the provider about African American women. They will not be able to do it, or they don't want to breastfeed, or they will not be able to make it. That actually negative assumption affected their quality of care. In terms of referral to lactation consultants, they have low rate of referral to a lactation consultant, and the breastfeeding education. They were not actually provided the lactation support that they really need, and in time, and education. And this is partly the racism, the bias, the discrimination are part of these disparities. So this is another study by Bartek. So she actually estimated the number of hypertension among mothers due to lack of breastfeeding, and the number of enterocolitis in preterm infant. So 1.3 more number of cases among Black mothers, and 3.3 more times of enterocolitis among preterm infant of Black women. So that's more compared to white mothers and white infants. That's actually as a result, or lower rate due to the lower rate of breastfeeding exclusivity and duration. So how can we address this situation? So this is also part of the breastfeeding equity. So we need to improve the hospital maternity care and lactation support. Each hospital now, they should have a lactation team. So a lactation team, they don't have to be certified, but they should be trained in how to support the mothers. And teaching or educating the mothers about the benefits of breastfeeding. Like when you ask the mother, would you like to breastfeed or like bottle feed or formula feed? So without any providing, this is unethical if you don't actually provide the information and the benefit, and they have the mother to like take the decision. We call it informed decision. She has to have the information and then decide, not just a choice breast or formula. Continued education of healthcare professionals. So we see a lot of healthcare professionals. Also, instead of actually referring the mothers to a lactation consultant to help with the issues of breastfeeding difficulties, or even the self-efficacy. So they also provide some formula, or it is okay to give one formula. So providers' education is very important. Now we have all the breastfeeding curriculum in the medical schools and in the nurse practitioners programs. So, and also in our nursing program, and all actually programs related to healthcare or maternal child should have the education for the providers about breastfeeding. Peer support, the WAKE offices also, they have training for like peer counselor or peer support, like teaching the, having the breastfeeding as a habit and need support. Boost the breastfeeding support in the workplace, the enforcement of, following the law or following the rules, and having the employer to have their, to support their breastfeeding mom. This is actually a very, very big step. Improve the access to breastfeeding education and the information. The prenatal classes is very, very important. Improved access to professional lactation support, as I mentioned, like each hospital should have, and in some states they have a lactation consultant in the pediatrician office. They have a lactation consultant in primary care for children, family or children. Supporting breastfeeding in the child care and kindergarten, or like child care, especially the child care settings, is very important. And the addressing the marketing of the infant formula. We have the International Code of Marketing breast milk substitute, actually prevent any advertisement of formula or sending free samples to the mothers. So we need to enforce this to be able to actually help, especially the target mothers of minorities, and especially also in the rural areas. So we cannot deny a lot of activities that is going on, and a lot of support. So reaching our sisters, those are programs that really support the breastfeeding and trying to address disparities in minorities. Reaching our sisters everywhere is a funded program that support African American mothers who are pregnant and need or intended to breastfeed, and also not just supporting the mother, also supporting the peer counselors or the mothers who want to be certified as a lactation consultant to increase, the lactation support from the same race and same ethnicity. The CDCs, they have breastfeeding committee, and this have having actually a lot of funding for especially for rural and the minorities areas to provide lactation support, and also they have their annual report about breastfeeding, and they have the guidelines and the strategies to support breastfeeding. The NACHO also, they provide breastfeeding support and grant to areas which underserved their population and target populations. And I didn't talk about the LGBTQ community, but we have a lot of activities that actually support parents who really want to breastfeed. And we have also this strategies to also increase or address the breastfeeding, increase access to cultural responsive resources, lactation credentials, or we support actually the minority nurses or anyone who would like to pursue the certification as a lactation consultant. We will encourage them to get the certification and increase the number of minorities lactation consultant. The policies and also the collaborative initiative for breastfeeding and IBC-LEC International Board Certified Lactation Consultant advocacy, and also increasing the wages for them. Implicit bias training, culturally responsive lactation specialist or education. A lot of training now is available for in terms of how to actually address the implicit bias and racism. So this slide is related to the language, inclusive language. The Academy of Breastfeeding Medicine just recently, last year, they have guidelines, position statement guidelines for infant feeding and lactation related language and gender, and that's actually encourage the inclusive language for LGBTQ community. The International Lactation Consultant Association also, they have a policy statement and for creating a safe, inclusive environment, and we have a guidelines for exclusive. We just finished and updated the guidelines for exclusive breastfeeding, and we implemented the inclusive language, and we also added more strategies to how to address disparities and how to address the racism and bias. So for my studies, I actually focus, like most of my studies, focusing on understanding the factors that really affect the breastfeeding outcome among minority mothers or low-income mothers. This is one of my studies, and I chose this one because we had like more than 64% of the sample were African American, so minorities. And I also did several studies with the weak mothers, and most of my results support the literature, which is like the breastfeeding rate among low-income mothers is low in terms of education and also location compared to white Americans or high income. So this study focused on sleep disturbance during pregnancy and its effect on delayed lactation. Delayed lactation, as I mentioned, is milk coming in within the first 72 hours postpartum, and we all know that the delayed lactation is one of the main factors that actually leads to early cessation or early supplementation of breastfeeding. Literature said or reported the metabolic hormonal link with the delayed lactation, with sleep disturbance and delayed lactation. So our hypothesis was short sleep duration and poor sleep continuity during pregnancy is associated with delayed lactation. And we wanted to understand and measure the sleep disturbance during pregnancy objectively, and we also did it subjectively. So we conducted a prospective longitudinal repeated measure observational studies at Eskenazi Health. And the Eskenazi Health, the clinics that we recruited the mothers from were in a high-risk area, which the high-risk pregnancy area and low-income area. 92 mothers, and we actually focused on the first-time mother, primiparous mothers, and we had the mothers actually recruited them in the first trimester, and we give them the active watches and the demographic data and all the tools during the 22 weeks, and then we repeated this. The mothers actually wore the active watches for seven days, 3 times at 22, 32, and 42. Not 42 at 1 week postpartum, immediately postpartum. We calculated the start and end sleep time, total night sleep, sleep efficiency, and woke after sleep onset and sleep fragmentation were measured. For lactation consultant, we had a research for delayed lactation. We had a research assistant at the hospital immediately after the mother gave birth. She assisted the milk coming in. And after the mom left the hospital, we sent her daily survey by text and or by phone for 5 days, for the first 5 days to assess the delayed lactation. And we also used the Pittsburgh Sleep Quality Index, and we assessed the breastfeeding outcome or the breastfeeding status around 1 week. So from this table, you can see 64 mothers, 64% African American, and less than, a lot of mothers less than like high school or less, and really very low income. So mothers were considered like delayed lactation if she has a score of less than 3. So, and you can see here we had more than it was more than 31% had delayed lactation, and that was really higher compared to other previous studies. We didn't have a control group, but we have compared to previous studies. We had a significant difference and in the breastfeeding, the sleep disturbance, like in the 32 weeks, and the sleep efficiency in the 32 weeks. So we have the difference in the third trimester was really significant relation with the short sleep duration and fragmentation and the woke up after sleep. For the breastfeeding data, we didn't have enough data, but we had most of the mothers, they actually started breastfeeding, but like exclusive breastfeeding among participants who had delayed lactation was really high compared to the one, was really actually the exclusive breastfeeding was low in the one who had delayed lactation. But we didn't have enough data about breastfeeding to compare to actually to see the continuation of breastfeeding. So this so we concluded that women with better sleep efficiency and more stable night sleeping are less likely to experience delayed lactation. And we are working on intervention actually to at least to assess the sleep during pregnancy and provide some education during pregnancy for mothers. But this is a very small sample size, and we submitted RO1 to implement it or a larger scale. We got scored, but it's not fundable yet, but we applied again. So talking about the sleep, the racial disparities in sleep is part of the big actually picture of disparities in maternal health, and we know that disparities in pregnancy, like morbidities and like mortalities among minorities, especially African American, is a huge problem right now, and breastfeeding is just part of it. And it really actually, I just focused on breastfeeding, but the big picture is really, it is the maternal child health. So I am done. I will.
Thank you so very much. I learned so much during this presentation and just really grateful to have had you speak.